All right, we are streaming, but I'm just going to hop over to Facebook to confirm, and then we will start the show.
Sorry, we didn't get a opportunity to promote the event.
No. I'm sure everyone will be excited to see you. Let's see if we have people joining the room so far. Usually they are waiting close by, and there they are. Yeah, they're filling up fast. Surprise secret guest. So let's not hold them any longer. Let's start the show. Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation and LACNet's program. My name is Rain Bennett. I am your host this episode and every episode. As you can see, it is the holiday season. This is our final episode of the year. I'm very excited to have you all here with us one last time. And if you don't know me, I'm a filmmaker and a writer by trade, and I've been working with CCF for over 10 years, and now LACNet's the past year or two to create all kinds of video content. So conference videos, patient-centric documentaries, treatment-based videos, live video series like the one that you will watch today, but all with the same singular mission in mind, and that is to raise awareness and education about neuroendocrine tumors. So here at the show at Luncheon with the Experts, the value I really see is twofold. One, of course, the information that you'll get from our guest today, and two, the shared experiences that you will and shared stories and support that you'll receive from within the community. So you may see people in the chat already signing on and saying hello from Tuscarora, Pennsylvania. Hello from Ottawa. Hey, Ottawa. Hello from Texas. If you're new to the show or new to this journey, welcome. I encourage you very much so to introduce yourself and embrace that community. I assure you they will embrace you back. One of my favorite things about the net community is how strong and supportive it is. So let us know where you're signing on from across the world. I love to see the reach that we have on these programs, and you can go ahead and start sending in questions. One thing before we get going, I always want to call attention to the support line that we have created with the merger between CCF and LACNets, and you can find that at lacnets.org/support line. We will try to put that link in the comments as well as any other references that we mentioned today so that you can easily access them. But the support line is great for anybody affected by NETs. So anybody needing support, patients, caregivers can fill out a questionnaire there, and any follow-up questions that you may have, just let us know. Well, today we had a little bit of change in plans. Our previous guest could not make it because, you know what? We often deal with doctors, and often doctors get pulled away for surgeries, for treatments, for patients. And of course, we want to support them in that endeavor because that's what we're here to do. So luckily, we have guests waiting that always are happy to join the show, like today's guest, who we didn't hear from not very long ago. And so there were some people that I think had follow-up questions or questions that didn't get answered, and great news, you get to get them answered today. So welcome back to the show. One of my favorite guests, one of my favorite people, Dr. Aman Chauhan.
Thank you so much, Rain. Welcome, everybody. Greetings from Miami. Wishing everybody a wonderful holiday season. And what a great way to finish my year. Thank you for this opportunity, Rain and LACNets and CCF.
I agree. We'll call it a happy accident. I'm very happy to have you back. I'm going to take this off now that I've made my festive statement because, you know, it's a little distracting and a little bit itchy, let's be real. But I know one thing, Dr. Chauhan probably doesn't need it down there in Miami, who's probably going to enjoy an 80-degree Christmas or so. For those that don't know your role there, you're still somewhat new. I know it's been a while now that you've been down in Miami, but tell the folks listening in attendance the role that you fill in this net community I alluded to earlier.
Wonderful. So blessed to be part of the net community, both regionally and nationally. So I came here to University of Miami Sylvester Comprehensive Cancer Center. We are an NCI designated cancer center, in probably the only one in South Florida. And I was tasked to start a neuroendocrine cancer focused program because we had a large patient population, large catchment area, and we didn't really had a dedicated multidisciplinary NATS program. So I came here about 2 years back, a year and a half, 2 years back, and set it up. It's been a wonderful journey. So I do a lot of, I have 2 days where I see neuroendocrine cancer patients. One of the unique things about our program is it is a net and neck program. So It's a site agnostic, so we see head and neck, lung, GI tract, gynonc, anywhere in the body. If you have a neuroendocrine cancer and of any type, any grade, small cell, large cell, those aggressive natures, or your typical carcinoids or the well differentiated neuroendocrine tumors. So it's a one stop shop for all neuroendocrine cancer patients. And we have a multidisciplinary tumor board with surgeons, nuclear medicine, IR, all sort of facilities that are needed for delivering excellent care to neuroendocrine cancer patients. Another hat that I wear is drug development. So I do phase one drug development. In fact, I'm running from a phase one clinic this morning because the breakthroughs that will happen in cancer and in our field will be through new drug development, new clinical trials. So I do a lot of first in human or phase one clinical trials. And that's where I spend a lot of time doing translational research, bringing good and exciting compound from lab to early phase drug development and human trials. So that's another thing that we do. And at the national level, I chair communication committee for NANETS. That's our official Neuroendocrine Cancer Society in North America. I also co-lead a neuroendocrine tumor committee subcommittee at SWOG, which is one of the cooperative groups, and then part of some guidelines committee. So happy to be engaged in direct patient care locally as well as policy making in the national level.
Got it. Thank you so much. So, folks, if you're joining us and you have questions to ask, you can go ahead and start queuing them up for me. One little request from my side of things to help make it easier to navigate. If you could ask them in little generic chunks, that helps us in this format. It's really hard to field questions that are super case specific or super dense. Dr. Chauhan will absolutely ask you if he needs a little more specificity or clarification, which sometimes we do to help answer the question a little bit better. But if we start really dense, sometimes it's hard to navigate those questions. There's no limit to how many questions you can ask, so you can always ask follow-up questions. And of course, if we don't get to your question or if you still have follow-up questions, I encourage you to reach out to the support line that I mentioned earlier. Okay, Dr. Chauhan, let's go ahead and get into it. We have questions coming in already. From Brent over on YouTube, and I love to see our YouTube crowd growing every episode. That's great. Brent says, from the AGCC, the American Joint Committee on Cancer, from the AJCC version 9, or the 9th edition, you mentioned that chromogranin A isn't warranted for all patients. So the question is, Dr. Chauhan, when should or shouldn't chromogranin A be helpful?
Great question. So for the unversed, a lot of people don't know what AJCC and what this version 9 is. Just let me kind of give a brief background. So AJCC is American Joint Cancer Committee. This is a federally commissioned committee that have disease-specific subcommittees. So I'm part of the Neuroendocrine Cancer Committee, and they meet every few years to update the staging of the cancer. If you know, our key metrics, how we treat the cancer is based largely on the stage, early stage, stage 1, 2, 3, and 4. But then who decides what is a stage 4, what's a stage 3, what's stage 1? This is the committee that looks into the outcomes and the management and what extent of disease spread led to what type of 5-year outcomes. Then, so AJCC, that's the main task of it. But skirting around that, it also incorporate evolving data for diagnostics, biomarkers. So we put together a comprehensive summary of version 9. So AJCC updated the guidelines for neuroendocrine cancer after several years. So this is a big jump from version 8 to version 9. So a lot of changes. And each sub-chapter, like gastric neuroendocrine tumor, appendix, or pancreas, it's a 30-40 page chapter in itself. I was tasked to lead the appendiceal nets. So it's very difficult for people to read, or a busy clinician to read, or a patient to read. So what we did, we published the consensus or the summary in easy to read and understand format in a small paper. And that's where Brent is alluding to, that we kind of summarize. So I'd encourage people to Google that paper, read it. I put some nice figures and diagrams to simplify what the cancer is, etc. So one of the comments we made there, based on the expert consensus, that routine use of chromogranin A should be dissuaded. Why? Well, this is a good test, and in its time and era did serve its purpose. Back in the days when we didn't have good ways to monitor the cancer or diagnose, this is one of the supportive evidence we used to do and check for it. The flaw of chromogranin A is its poor sensitivity and specificity. That means it's not accurate. It's like a flip of a coin. So if you are seeing elevated chromogranin A, it could be from neuroendocrine tumor, it could not be. In the current era, it is not good enough for us to just it could should, right? We have molecular diagnostic scans like dotatate pets, which are highly accurate, 95, 97% in terms of accuracy, specificity, sensitivity. So the bar of our threshold to what test we should use in helping us understand is there disease or not is getting higher. So many times when we see patients from community doctor, they'll use it very casually and it'll be elevated and it'll freak out both the doctor as well as the patient. We want to at least minimize those issues. So routine use of chromogranin just to kind of check, oh, my tumors have been resected, now let's me follow chromogranin A to see if it's back. It's not the accurate way. It might lead you down the wrong pathway. So the consensus from the expert panel, and it included net specialists from all over the world actually, was that this is not good enough in the current era. However, we all use it once in a while because for select patient where we've been tracking it and it correlates nicely with the disease burden on the CT scan or the scans, for those select patient it might be very accurate, but for larger population, this is meant for everybody out in clinic. Somebody is suspected net, should you do a chromogranin and it's high, you say this is a net patient? No, that's what we are trying to dissuade. This is not accurate enough to establish a diagnosis. You have to find the tumor, see the tumor, and the biopsy the tumor. This is not good enough anymore. However, there are some recent publications that are again suggesting that some support in using chromogranin in select patients. So this will be an ongoing discussion. But for the time being, okay to use under specialized care where people know how to interpret that result. So a net specialist will be a good person to help and order it and put it in context for you, but don't use it indiscriminately out in community clinic without putting in a context, and might actually freak you out because there's so many things that can cause chromogranin to go up, including some antacids, right? So not no longer routinely used.
Got it. Thank you. Thanks for your question, Brent. Let me know if that helped. And of course, if you have a follow up question. Next question, I really like this. It's one of those questions that sparks a discussion or conversation. Robin says, how many specialists should be on a tumor board? So let's talk a little bit about the importance of that and your opinion on that question.
um, a tumor board should have all the necessary expertise, and that means it should have a surgeon on board, it has a radiologist, it has a pathologist, a medical oncologist. Not everybody needs to be a net specialist. Okay. So if I have a patient who I believe may benefit from surgery, but I'm not a surgeon, I'm not qualified to tell the patient the risk, benefits, outcomes, short term outcomes, or complication risk, etc. I need a surgeon. That surgeon doesn't have to be a net specialist surgeon. If it is going to be a lobectomy for lung, or the surgeons follow a certain set of surgical oncology principles, and they can weigh in, this is a good surgical case or not, is this patient fit enough to get surgery or not, what are the potential complications. So we need area specific expertise, so that if you don't have it in a tumor board, then it's incomplete. So you need all of them: one surgeon, interventional radiologist in case you're considering liver directed therapy like embolization. You want to certainly have a radiologist so that they can interpret the scans. You don't want to be reading your own scans. I'm not very good at reading my scans. I can do a semi job, but it's never going to be as good as a board certified radiologist who does this for a living. Same thing with nuclear medicine doctor. They are board certified. This is what they do. They read the PET scans, the dotatate PET scans. So having them on board and weighing in, if I see a spot on the scan, I say, doc, what do you think? This is a metastatic net or this is inflammatory? So I take their opinion over my opinion because this is what they do. This is expertise. But not all of them have to be net specialists. that is asking for too much. We don't have that many net
Yeah.
specialists, and it's not even needed. You need one doctor who is interested and passionate, but is going to be a quarterback and had all these important pillars of medicine that are needed for proper cancer care.
I like that analogy, the quarterback analogy. That works. Great. Thank you so much for your question. Moving on. From Antoinette, is obstruction of the abdomen common? We may need more information there. I'll let you address that, but that is the question.
Right. So one of the commonest site for a well differentiated neuroendocrine tumor, the site of origin is midgut, small bowel. That's one of the commonest area where this starts. And many times when it starts in small bowel, it presents either locally just in the bowel or loco-regionally with mesenteric masses or bulky disease around the small bowel in the lymph nodes in around the soft tissue called mesentery. If you have a lot of disease there, because of the proximity of the bowels, yes, there is always a risk for obstruction. The so many factors, right? One, if we are dealing with a very tiny amount of disease, probably unlikely or less likely. But if we are dealing with a big, bulky mesenteric disease, yes, there could be concern for obstruction. Some other common reasons for obstruction in NET patients are patients who have had surgery, especially if multiple surgeries. Sometimes they develop strictures or scar tissue, and then that could lead to an obstruction. Although that's never an intention. The intention of surgery is to debulk the cancer, get rid of most of the cancer to prevent future complication. But sometimes that happens. That's also one of the reasons we see obstruction. In the era of PRRT, that's a latest radiopharmaceutical drug. It's a targeted radiotherapy drug that we give systemically through IV infusion, but targets the tumors. So if we are treating a patient with small bowel disease, a lot of mesenteric disease or peritoneal disease, because this radiation will go in there and start radiating the tumor, and there'll be inflammation. As it kills the cancer cells, there'll be inflammation and swelling that can cause obstruction. So after PRRT with patients with bulky peritoneal disease, they are at risk for small bowel obstruction. There is a small risk that has been defined in literature. So lately, what we've been doing is, and this is not a common practice, but many NET centers, they are giving a short course of steroid after PRRT in patients who are deemed at risk for obstruction. Those are some of the scenarios where we see obstruction, but of course this is a very broad topic. So I'm giving a very broad answer.
Yeah, absolutely. Thanks, Antoinette. Let me know if you have a follow-up question or if that answered your question. Next one comes from Rhonda. Rhonda says, I've had carcinoid tumors 2 different times, appendix and pancreas, as well as small intestines. And this is another big question, but I understand where Rhonda's coming from. She says, can you continue getting carcinoid tumors after having this 2 different times?
Absolutely. So if it happened once, it can certainly happen again, right? Neuroendocrine cells are peppered throughout your GI tract. If there was something abnormal in the cell that led it to become tumorous and abnormal growth, it can certainly happen at other places as well. So I would not say it will never happen once you're resected and the primary tumor is gone, then you have 0% risk. But the data does support us. That means for an early stage neuroendocrine tumor or small bowel, if we look into patients who were resected early, stage 1, stage 2, the chance of them having another tumor in 5-10 years is very less. The odds are in your favor that you will be cancer free in next 5 to 10 years if you were detected early. It was stage 1, stage 2, but it's not 100%. There will be these small fraction of patients where it might come back either at the same site locally or distantly, or you can have another tumor in your another area of GI tract. So surveillance is important. The longer you go out after your primary surgery without evidence of cancer coming back, the better we feel, and less frequently we need to monitor. But there will be always a small risk of this coming back.
Got it. Thank you. And thanks for your question, Rhonda. Next one comes from Joy. Joy says, what type of therapy might be suggested for NETs on the pelvic bone and spine?
Great question. Bones are among the top three places of metastasis. So, liver probably number one, lymph node, and then bone is among the top three. So, it's not an uncommon place for nets to go and migrate. How do we manage it? Really based on two factors: the burden of disease. So, if we have many, the entire skeleton or a lot of different bones studded with tumor and a lot of cancer, unfortunately, then I often use systemic radiation, that is PRRT, works really well. But if we are looking at small volume disease, one or two or three areas, focal radiation sometimes does the job very nicely, especially if these bone mets are causing patient to have pain. Especially, in this patient, it's pelvic area, so could have some pain during walking or some exercise. And one of our goals is to improve quality of life. So if the pain is happening and there is a discrete lesion we can see on the bones, it can be easily managed with a very few fraction of radiation, and you don't have to expose the whole body to radiation with PRRT. So I would consider local radiation or external beam radiation for palliation, especially if there's pain issues, and reserve PRRT for future purposes when there is more disease. But again, these are very case specific nuances. I'll have to study the burden of disease and symptomatology for a fine tuned answer.
Thanks, Joy. Appreciate you and your question. Moving along, next question comes from Sarah. This is an interesting one from my perspective. Sarah says, is it true that grade 1 carcinoid tumor isn't actually cancerous?
Um, it's not true. It can be cancerous. So the distinction between cancer and non-cancer. So let's kind of go back to some basics first, right? So there is neuroendocrine neoplasm. Neoplasm means any abnormal growth, right? Um, like a lot of people have lipomas, fat, right? So it's an abnormal growth of adipose tissue or fat tissue. It's not a cancer. So not every growth is a cancer, right? So neoplasm is a broad-based umbrella term. It just suggests it's an abnormal growth. Now there can be two type of growths, abnormal growths: benign growth and malignant growth, right? So neuroendocrine tumors can also be of two types. They can be, certainly there are some neuroendocrine tumors which are benign. That means they have grown abnormally, and it's just local, but they don't have the potential to become cancers. That means they're not going to metastasize. They're not going to invade other organs or spread and go invade another organ. Okay, but there are some neuroendocrine tumors, including grade 1, grade 2, certainly higher grade are aggressive. But even for grade 1, we have plenty of patients. In fact, most of our patients are grade 1 with metastatic disease. So they certainly have potential to be cancerous. We cannot tell one for other. So if somebody is diagnosed, and I have a patient who underwent colonoscopy or endoscopy and for a small polyp, right? Could it become cancerous in the future or become metastatic, or it has potential to be cancer? I can't tell based on this stat. It's a neuroendocrine tumor. It has a potential to do that, right? So we take care of it. We don't leave it. If we truly felt that it is benign, don't touch it, just leave it there, then we would keep it there. We do not worry. But we can't predict the future behavior of that tumor. So yes, I agree with the question that there are some patients for some neuroendocrine tumors which may be benign, and patient might live their whole life without it kind of growing further or metastasizing. But there's no good way for us to tell one for other. There are many neuroendocrine tumor patients grade 1 that have potential to become metastatic, so can become cancer. So it's one of those diseases that has both the flavors. So we treat them like cancer, right? We have to treat them like cancer, and because they do have potential. And I'll give you some stats. Patients who have metastatic neuroendocrine tumor, that means stage 4, it's already spread at the time of diagnosis, the 5-year survival is somewhere 50 to 60% range. So it is a fatal disease. It's not to be taken lightly. Okay, and right management, right time is important, especially if it's caught early. It can be cured, and largely for most patients by just surgery alone. So again, timely management is very important, not to be taken lightly, not to be taken, oh, this is all benign.
Yeah.
And yeah.
Thank you, Sarah. Hopefully that helps. Next question comes from Josh, and this is a common issue I have found. What do you recommend if the tumor is not found? I've had a positive REN test. I have many symptoms. I'm on octreotide and still feeling crappy most of the time. Had all scans, PET, dotatate, MRI, CTI or CT, endoscopy, and colonoscopy. Nothing is showing. So the question is, what do you recommend me doing to treat and or find it?
Yes, unfortunately, it is not unheard of. These neuroendocrine tumor unknown primary. One of the follow up is so we just don't know where it is or the site of primary origin, or there is no detectable tumor at all.
The only thing that Josh says is the positive REN test as well as the symptoms and has been on octreotide but still
Right.
feeling crappy. But all the other scans, endoscopy, colonoscopy, nothing is showing.
Yes. So yes, tough case, and we all had some of those. Feel bad because patient is symptomatic. They know they have disease. We just can't see it, or our current technologies are not good enough to detect it.
Hmm.
Your PET scans are very good, but they cannot detect if the tumor is less than 3 millimeters. So they every technology has a threshold of what it can detect or it cannot, right? So based on the symptoms and response to octreotide, it seems like patient has neuroendocrine tumor. We just don't know where it is, and sometimes that happens. A rare situation, but can happen. So if you have had a colonoscopy, you have an endoscopy, you have a PET scan, that's almost the entirety of full workup. Some centers, if they have capability, they will do double balloon push enteroscopy, so they are able to scope the whole length of small bowel. That's one of the places where these type of tumors do start. So a routine colonoscopy don't go to your small bowel. So the double balloon push enteroscopy is one of the ways to do it. If this technology is not available, then sometimes they will do a capsule endoscopy. That is a small pill camera that you take and goes throughout your small bowel. It does have a chance of missing out because it's really dependent on gravity wherever the camera is revolving and going. So not as good as endoscopy. So those are some extra steps that you can consider if the standard diagnostic workup is not yielding benefit. But the next step to do is just surveillance. Keep looking for tumor showing up on one of the future scans. In meantime, continue medicine that is helping you live a better quality of life with octreotide. But whenever there is a suspected spot on one of the scans, the next step would be a biopsy to confirm it.
Absolutely. I appreciate your question, Josh, and sorry for that. I know that's got to be frustrating. Folks, if you just joined us or joined us a little bit late, this is Luncheon with the experts at Carcinoid Cancer Foundation and LACNet's program. And today we are here for our final episode of 2024 with the world famous Dr. Aman Chauhan from down in Miami. He liked that one. I saw that smile. We're going to continue on. Great questions so far and great answers from you, Dr. Chauhan. Appreciate you as always. Next one comes from Pamela. Pamela says, my net tumor has returned after 11 years. That is frustrating too. Sorry, Pam. It's now a 7 millimeter mass identified per the dotatate scan in the LLQ. Nothing is being done per my net specialist. My earlier nets was small bowel and valve area with 11 lymph nodes and liver wedge resection. Should we be doing anything? I think that Pamela might be a little frustrated and want to take some action, and nothing is being done per her net specialist at the moment.
Right. Sorry to hear the cancer come back, and again, we were just saying the same thing. Many patients will be cured, but some, the cancer can come back, and it can sometimes come back years later. So I never say 0% risk of relapse, right? There's always a small risk. If it has come back, there are a lot of things that to factor in, right? One is what's the burden of disease. So if it's just a small volume disease, like patient mentioned, in left lower quadrant, and rest of the scans clean, I would certainly urge patient to have a consult with the surgeon, see if they can resect it. You had a several years of disease-free period with just surgery, and if they can safely resect it, and there's no concern of it locally invading something that they cannot get rid of, or surgical from safety standpoint that you're fit candidate. I anytime you have a small volume local disease that can be resected, you need to have certain way and see if this can be taken care of surgically. The other approach could be that you observe it closely and get to understand the nature of this cancer. Is it slow growing, fast growing, etc.? Um, Ideally, you want to biopsy it if it is biopsyable, because you do want to know what you're dealing with. Is it the same grade of tumor that was originally found? Is it a different grade? What's going on? And then, of course, the scans are pretty good, but they're, again, not, they don't replace gold standard, which is a biopsy, right? Our grading or everything is based on the actual tissue when the pathologist looks at under microscope with naked eyes, right? So if it can be biopsied, you want to do that. So sometimes doing surgery can serve both purposes, both diagnostic and therapeutic. They get the tumor out. They one confirm that okay, it was a relapse disease. Second, they will also get rid of it, right? So those are the two approaches. Seek a surgical opinion, see if you're a surgical resection candidate. If not, close monitoring, and if it's not growing or it's, you can continue to watch it. And if it is growing, then you have systemic treatments. But again, for very low volume, few spots now showed up few years later, I would hate to start somebody on systemic therapy for lifelong if it can be resected, and then you don't have to be on treatment. So a good case for a multidisciplinary tumor board again.
Yeah, good point. Thanks for your question, Pamela. Next one comes from Claire. Hey, Claire, good to see you. With new and emerging, not yet FDA approved treatments, or which new and emerging treatments are you most excited or cautiously optimistic about? And bonus points if they'd be applicable to atypical small cell stage 4 lung primaries with extensive mets, including liver, bones, and very few dotatate avid tumors. So, did you get the main part of the question there?
Yes.
Okay.
So again, very open-ended question. I
Yes.
do deal with neuroendocrine tumors, neuroendocrine carcinomas, different diseases. So there are different excitement for different diseases. I think most of the patients here belong to neuroendocrine tumor, well differentiated, typical or atypical lung carcinoid. So from that standpoint, I think the latest and greatest. So we had a lot of really good drugs. Now, as we have plenty. PRRT is a fantastic drug, etc., etc. But the latest entrant in the market is cabozantinib. If you Google cabozantinib cabinet study, it was recently published in New England Journal of Medicine. It was a large clinical trial that tested cabozantinib as once a day pill, as and compared to placebo, and was found to be very effective regardless of where the tumor started: pancreas, outside pancreas, lung, higher grade. They included some higher grade tumors, like the patient was mentioning, the atypical carcinoma. So, and it doesn't depend on receptor expression. You don't have to be somatostatin receptor positive or negative. That's one of the challenge when it comes to atypical carcinoid, because some of the traditional treatments like sandostatin, lanreotide, PRT may not be useful for us if they are somatostatin receptor negative. So our options are limited. Cabozantinib sort of is agnostic to that, so it can work on anybody. So out of the newer drugs in last 12 months, this is probably the newest breakthrough in our NETs field, where we have this drug. We have found that it works, and can be used especially for atypical carcinoid. Having said that, for individual patient, atypical carcinoid is a very challenging disease because it's truly a middle of the road cancer between aggressive high grade neuroendocrine carcinomas like small cell, large cell, and a low grade typical carcinoid. So sometimes I've seen atypical carcinoid behave very slow growing, indolent, like typical, and sometimes I've seen them growing very aggressively, fast growing like small cell. So you really have to understand individual patients' disease trajectory and biology, and pick and choose treatment accordingly. You don't want to treat somebody with cabozantinib if it's behaving more like small cell lung cancer with brain metastases. But majority of atypical carcinoid will behave more like your well-defined NETs, and then cabozantinib is a very welcome addition to our armamentarium for thoracic NETs.
Got it. Thank you so much, Claire. From Christine, if you get alpha PRRT first and then get progression afterwards, can you do beta after, or would you do alpha again further down the road?
Um, this is really uncharted territory.
Uh-huh.
We have FDA approval of beta PRRT right now, which is called Lutathera, and it's 4 doses one time.
Hmm.
But we also know the patient at progression, they still have somatostatin receptors, and most patients have more room for getting more radiation-based treatment. It's not fully vetted yet, and there are several trials ongoing right now testing alpha PRRT and another round of beta PRRT. So we are challenging, pushing our limits. How much more radiation can patient get? We know from some smaller studies in Europe that yes, patient can get more PRRT. So right now we are at a stage we are doing retreatment, so alpha PRRT. What patient is now asking me is re PRRT. So patient has beta, now alpha, and now going back to beta. If I understood correctly, unless patient went straight to alpha in some clinical trial and then wants to try beta, certainly it's a possibility. But if it's re-PRT, that means already had one round of beta, now one round of alpha, I'm little worried about, is patient going to be able to tolerate more radiation? No, these are targeted radiation-based treatments, so they preferentially go to tumors, but there is some exposure to systemic, so that's why you see some low blood counts and low platelet counts. So we'll have to make decision based on individual case. If there are absolutely no other treatment options left, there are no FDA approved or other good treatment options left, like cabozantinib I mentioned, Afinitor, so the other usual tools we have. There's nothing left, but and patient has good marrow reserve, but blood counts are good, kidney numbers are good, and the PET scan showing good uptake in the receptor, you may consider going back to beta PRT, especially if you had good response early. Now, if you tried the beta PRT in the past or alpha PRT and the response was very short lived, then you know this drug is not helping your cancer and you don't want to get exposed to more radiation without any major benefit. But if you tried it in past and it gave you some reasonable control and there are no other alternatives, you can certainly consider, it'll be considered off label, but you can consider, and these drugs are available in market, so you may have a good shot at getting it. So again, not an easy answer, unfortunately. There are a lot of variables, but it's doable.
Got it. Thanks. And well, sticking in the theme of PRRT, Lorraine says, what is the recovery time typically for PRRT? And two, what are the typical side effects?
PRRT is one of the most well tolerated drugs, and of course it's you have to compare it to, I'm talking in comparison to some chemotherapies we use, very harsh and toxic. um, so that those are some of the benefits that we like, and it has been welcomed in our field so well because it's 4 doses, it's easy, it's well tolerated. However, things to be careful about, most patient will have some degree of fatigue. Now it's a radiation, at the end of the day your body is getting radiation and it's trying to fight the cancer, but there's some degree of radiation exposure to normal organs, so you will expect some fatigue, especially in the first month, and that goes away very fast. This does not lead to profound amount of fatigue where you cannot function. I have patients highly functional, they work, they do all sort of stuff. So the fatigue is mild, it's not severe. Some patient will also have a little bit of nausea. That's not really from the drug, but from amino acid that we give along with the drug infusion to protect your kidneys. So this nausea can linger on for a few days after the infusion. The amino acid we use currently is a lot superior, better, and it does not cause terrible nausea. The one they used in the trial was pretty bad, and that's why if you look at the trial numbers with nausea and vomiting, it was through the roof. But in real world, the amino acid we use is very safe. Many patients won't even have any issues with nausea, vomiting. Some may have little, so we prescribe some Zofran and Compazine, so they have these things. Those are by far the two common ones I see. One of the very scary side effect, but fortunately very rare, is long-term side effect of another cancer like MDS or leukemia. Now that risk is just 1 to 2%. but it is not 0%. So this is something that I educate patients on what that risk is. In the grand scheme of things, the drug is fantastic. In fact, they studied quality of life with that drug, and it actually improved the quality of life for NET patients. So, unlike many cancer drugs where it helps cancer, it helps fight the cancer, but at cost of quality of life. This drug not only helps fight the cancer, stabilize the cancer, but also improves the quality of life, at least in the trial setting. So, very, very good drug in sense, and also relatively safe.
Got it. Thank you, Lorraine, for your question. And still sticking with PRRT, Joy says, is there any concern with PRRT or localized radiation if osteoporosis is present in the body?
Um, That's a good question. So, in general, there's no added risk. It's not going to make your osteoporosis get worse.
Okay.
It's an independent process. The osteoporosis, if you have osteoporosis, needs to be definitely managed, and you need to be on appropriate, vitamin D, calcium sort of replacement drugs. But there are patients who have a lot of bone mets, and this drug's going to go wherever their bone mets and treat it, right? So it's not necessarily making osteoporosis worse, but could there be some added cytopenias, low blood count, because there's a lot of marrow involvement, etc. It's a possibility, but from your specific osteoporosis standpoint, I don't think there's any worsening of osteoporosis from it. Osteoporosis certainly does not need to be brushed under the carpet. You need to manage it appropriately, but I don't think the PRRT will make it worse.
Got it. Thanks, Joy. Next question from Mark. Mark says, I have a small bowel tumor, 3 centimeters, found in May. Surgery has been canceled 3 times and currently on hold as anesthesia will not give clearance due to COVID induced asthma. Lots of thick mucus and coughing every day. Asthma workup is negative and medication has not helped. Oncology will not see until after surgery. So lots of frustration there too, I imagine, Mark. And the question is there anything, medication, test, etc., that I should or could be doing in the meantime, as surgery may not be for 3 or 4 months?
Right. Yeah, I'm sorry. I understand your frustration. If this was a more aggressive cancer, certainly we would recommend certain systemic therapy as a bridge to surgery if there was some delay outside our control, which the surgery team anesthesia has to work it out. And they, of course, they also don't want to. It's easy for them to do surgery, but they want the best possible outcome for you. They don't want you to be end up in ventilator, and it's difficult to extubate you if they're worried about your lungs. So I'm glad that they're doing their due diligence, but it comes at a cost of frustration of waiting. Um, but in meantime, based on the nature of the cancer, we decide how aggressive we need to be. If it's a typical low-grade, well-defined neuroendocrine tumor, it's a slow-growing tumor, and you may have had it for several years before undiagnosed. So 2 or 3 months won't change much in the grand scheme of things. And our treatments, unfortunately, are cytostatic for most part. That means it won't make it disappear either. It at best will put the brakes on the cancer from growing more. So um, if the delay is just for few months, couple of months in for surgical planning, I don't think there'll be a whole lot that we will gain by starting treatment in the short term. The treatment usually is somatostatin analog. So I'd like to just reassure you. But if it was more aggressive tumor, like a high grade 2 or a grade 3 tumor, I would feel uncomfortable just sitting on it, and I would probably do something rather than nothing till we can get you definitely treated with surgery for early stage cancer. So it depends on the grade and the tumor growth. So while you're waiting and watching, you need to be observed for tumor growth rate. So I would say, get a scan if it had been 2 or 3 months already. Get a scan, see, okay, things are stable. If they are, then you don't have to worry much, and just kind of work with your surgery team to get you operated in the safest possible manner. Don't worry, these type of tumors, these slow growing tumors, can take years to grow sometime. So a couple of months is in that scale of things are not problematic.
Got it. Thank you. Switching gears a little bit, Sasheen says regarding carcinoid heart disease, some protocols don't advocate echocardiogram until BNP is elevated. I have just had CHD, severe tricuspid regurgitation, confirmed. Thankfully, damage is limited to the tricuspid valve. Why is there such a discrepancy between the echoes for all the carcinoid syndrome versus only in the setting of elevated BMP? Seems finding the regurgitation early will only benefit the patient. Thoughts?
Yes, I don't think there's a clear consensus, to be honest. It's an evolving landscape. There's going to be some new data studies in near future that will throw some more light on how to monitor BNP, role of BNP, ultrasound, cardiac MRIs, all sort of stuff. Um, Largely speaking, things are looking more favorable. Like previously, we used to see a lot more patients with carcinoma heart disease because of poor diagnosis, poor treatment. In the current era, the diagnosis of carcinoma heart disease is very small. It's truly rare because we are getting better at picking up patients who are at high risk. Those are the patients with high serotonin levels, and kind of bringing the serotonin down with proper medical management. So it's getting less and less common. But for those who are still at risk and or have this, the guidance is sort of like, all over. I don't really rely on BNP on my practice. So if I have a patient with carcinoid syndrome and elevated serotonin, I like to get a baseline echo and then some sort of a yearly echocardiogram to keep an eye on valves and cardiac function in general. And if there are any concerns, then we connect them to cardiology for appropriate monitoring. Many of them, they can be properly monitored, and do not need intervention unless there's true concern. And I'm not sure if BNP is truly the gatekeeper of it. At some places it might be. At my practice, I routinely do echocardiogram, and I've never gotten a pushback that no, you have to show me a elevated BNP to do an ultrasound of heart. Again, also have to be judicious in picking the right patient. So if somebody who has no cardio, the non-functional net, not at risk, I would not do it. Everything that we do has costs both for patients and healthcare. So you have to pick the patients who are your typical patient for at risk for cardiovascular heart disease.
Got it. Thank you. And thanks for your question. From Ruby, can you have a hip replacement if you have Mets all through your pelvic area?
Oh, great question. This is a difficult one for a med onc. I would really rely on a good orthopedic surgeon to help me with that. Um, and it really will depend on the skill set of the surgeon and what they can and cannot do. At the end of the they have to stabilize the prosthesis to the bone, and they need healthy bone for that. So if there are none, then that might challenge. But this is a very surgical question. I'm sorry, I'm stepping out of my expertise here to address that, and I think a surgeon will have to tell you about that. Just at face value, I will not uh, deny anybody a joint replacement just because they have bone mats,
Hmm.
right? But the extent of bone mats, the where it is, that might cause problem in surgeon to kind of do the surgery or do the job properly. And you don't want to do the surgery and have a new hip and just for that to dislodge again because of the weak bone. So I can see their concern, but this is a surgical question.
Got it. Hey, thanks, Ruby. From Shane, recently released data from NANETS regarding MEN1 and DAX mutations in PNETs has helped us make a decision in my mom starting PRRT. Do you know if more work is being done on looking into those mutations or these mutations?
Yes, there have been a lot of studies looking at studying the genomic profiling, and the next generation of studies are going to now look at what these mutation means in terms of treatment outcomes or just general disease related outcomes. So the first wave of studies in last 5 years were discovering what mutations do we even see, because 10, 15 years back, there was very little data on the molecular underpinning of these cancers. What are the mutations we see? What type of. Now we have defined that. There's plenty of data. The next set of studies need to now look at patients who have DAX mutation or ATAX, or with regards to the outcomes on certain treatments, right? For example, you got PRRT. We don't have good quality data to say patients who have this mutations, they have better outcome with PRRT for that particular mutation. And this type of data takes time to generate, right? Because PRRT itself was FDA approved in 2017, 2018, right? So these are relatively newer drugs. The NGS is not routinely done in most patients, especially for NET. So these are going to be done in more research setting. So we just don't have uh, convincing data yet. So as of today, I'm not using these mutations to select who gets PRT, who does not. We select patients who gets PRT, who does not, based on the dotatate PET, based on the somatostatin receptor expression, based on individual patient needs and availability of alternative treatments. Molecular genetics, biomarkers are still not ready for prime time in helping us which patient should get PRT first, which patient should get Afinitor first, which patient should get cabozantinib first. We're not there yet. We just don't have that good quality evidence. But there are studies, for example, my good friend, Dr. And Dedira Del Rivero, she's been here before, you know her, and she's doing a natural history study at NIH. The beauty of that study is patients are being followed, so they know the mutation at baseline. They will also then eventually know what treatment the patient got in future and how the outcomes were. And those kind of studies, when they read out 5 years later, and they'll have to constantly update it every 10 years, that's how we will learn what these mutations are are they meaningful in predicting outcome to treatment or not.
Got it. Quick follow up question. Shane says, do you get an MRI midway through PRRT to assess efficacy? How can one distinguish between tumor swelling versus actual progression at this point?
Yes, I do scans midway the PRRT, but that's because I do a lot of PRT trials, and in the clinical trial setting, we have to study the tumors, and there are a lot of scans built into the lot of research study. But if it was a standard of care patient, I oftentimes do my first scan after 3 rounds. So not truly midway, but after 3 cycles of PRRT. And the reason why I wait for three is because if I do scan too soon, sometimes I see just some tumor swelling from inflammation that is caused by radiation induced damage. So, very rarely we see any shrinkage in the first scan, if at all, stable disease to maybe sometimes worse disease. So, first scan is usually not very helpful in determining anything. After 3 rounds, we are sort of hitting 6 month mark, and I start getting a little nervous. It's a long time that I don't know what's happening inside the body. So I often do a scan after 3 cycles of PRT. Also, 3 cycles of PRT is a lot of treatment. By then, I should be able to see some benefit, at least stability, if not shrinkage. So that's, I feel it's a good sweet spot to do a scan. However, at the end of the day, the bottom line would be dictated by patient itself. There are very few rare patients who are not going to respond to PRT. We call them PRT refractory patient, and they will manifest itself. You've done 2 rounds of PRT, they're losing weight, they're getting sicker, they're getting weaker. You know something's not working. Those are good candidates for an early scan. And if there's clear evidence of progression, a lot of worsening disease, a lot of new disease, you know it's not working. You change the treatment. For majority of patient, a very early scan after 2 rounds is usually, in my experience, because I do a lot of trials and I do these 2 month scan, 2 cycle scans, it's sort of useless because most of them we don't get a good assessment of disease. Some might even look worse because it's sort of pseudo progression. It's the tumor is inflamed from all the radiation damage.
Got it. Thank you. From Sean, does biopsy increase the risk of metastases, or does that risk increase or reduce with the skill of the person doing the biopsy?
Biopsy with the current techniques and the current instruments they use does not increase the risk of metastases. Biopsy is very important. Good quality biopsy is very important in establishing a clean diagnosis. If we don't get a good diagnosis, everything would be wrong in terms of choosing the treatment and management guidelines. So it's very important to get a good quality of biopsy and not just a tiny little tissue or a hurried biopsy.
Hmm.
And I want to reassure everybody here, biopsy does not increase your risk.
Got it.
Getting early biopsy, getting a good diagnosis is very, very important.
Got it. Thanks, Sean. From Tara or Tara, any treatments that can be used after having angioplasty and being diagnosed with congestive heart failure? I've been removed from CAPTAM due to risks to the heart.
Do you mind repeating it? So,
Yeah.
any risk with
Well,
angioplasty or what
the
else?
question was, are there any treatments that can be used after having angioplasty and being diagnosed with congestive heart failure?
Right. Um, hmm. So we'll have to be cautious in this situation. But I don't think there are several treatments that they don't have absolute contraindication for heart. Um, PRRT, as long as patient can handle the volume. So certainly I like to have a cardio-oncologist or a cardiologist on board and understand what can and cannot be done. But from mechanism of action standpoint, there's no cardiotoxicity with PRRT. Afinitor is also not a bad drug. There's no direct cardiotoxicity with this. Um, uh, Cabozantinib, I'll have to look into it because such a new drug, but that's not one of the common side effects that I can think of, the cardiotoxicity. So there are a lot of drugs that you can do for from cardiac standpoint. Again, we'll have to understand your individual ejection fraction, how much fluid you can handle, etc. But there are some options for sure that are not traditional cardiotoxic. Some of these chemotherapy drugs, like Captem, so 5-FU part, the capecitabine, that can be cardiotoxic. But we oftentimes don't use hardcore chemotherapy for management of NET. So we might get lucky and we can use some of these targeted therapies to manage your cancer.
Got it. Thank you, folks. We just a few seconds or minutes. I'm gonna keep going. Tanya says, "What after PRT might be available when I am allergic to octreotide and lanreotide?"
What?
Okay. So stage 4A just received PRT last summer.
Uh-huh.
I'm allergic to octreotide and lanreotide. Are there any other treatments available when you can't use octreotide or lanreotide?
Absolutely. So it's a rare issue. Once in a while, we'll have allergy situation, cannot do these wonderful drugs, sandostatin and lanreotide. In that case, you basically just wait and watch, right? And PRT effects can last for a really long period of time. At time of progression, yes, you can then try. As I mentioned, Afinitor is one of the option. Cabozantinib now is a new entrant, another option. Retreatment with PRRT, if you've gone long time after the initial, would be another option. There are a couple of trials, Action 1 looking at alpha PRRT rechallenging. Our own study, Net Retreat, that me and Simran Singh are leading, is trying another round of beta PRT after progression on PRRT. Besides those, if it is a pancreatic neuroendocrine tumor, CAPTEM could be another option. Sunitinib. So as I mentioned, there are several options. There's no hurry. It's a marathon, not a race. So use your options appropriately at the right time when the tumors are progressing. For maintenance, yes, we do somatostatin analog after PRRT. That's how it was studied. But for some reason, if you can't take it because of allergy, don't worry. Just don't take it and wait for the cancer to progress before you start the next line of therapy.
Got it. Folks, I'm so sorry. We are just out of time. We had a lot of questions today, but some news for you regarding those questions we didn't quite get to. One, I'll reiterate again, reach out to lacnets.org/support line. And two, we will be back next year. We're going to have the same cadence every 2 weeks. We're going to try to start the first and third Thursdays of the month. That may change a little bit. So stay tuned for the exact dates. We'll be promoting it. But the long story short is we will be back back twice a month again next year due to your request and backed by popular demand, as they say. Dr. Chauhan, thank you so much for being here and filling in last minute. Everybody thank Dr. Chauhan. He's so amazing and came on board just yesterday. Appreciate you being here as always.
Thank you so much, Rain. Happy holidays, everybody. Merry Christmas, Happy New Year's, and would love to be back in 2025. Stay strong, everybody.
Absolutely. And thanks to you all at home for joining us. I hope this program helped answer some of your questions as always, and stay tuned for information about next year. Finally, my name is Rain Bennett. I have been your host. Thank you for watching, and please join us next time, next year in 2025 on Luncheon with the Experts. Stay healthy, stay safe, everyone. Bye-bye now, and happy holidays.